The main indications for shoulder arthroscopy are if you have a rotator cuff tear, so a tearing of the tendons inside the shoulder joint, and also a condition called subacromial impingement where the shoulder is impinging. And the third indication would be instability, so if your shoulder is dislocating or unstable, which can manifest in various ways. Typically the shoulder itself, the pain can appear in all sorts of different ways, which can be a bit confusing. So typically with shoulder pain, if you have a rotator cuff tear or impingement, you may get pain up into the neck, in the trapezius muscle. You may get pain and numbness behind your shoulder blade because the shoulder blade is balancing the shoulder. And you may also typically get pain down the shoulder to this area here. So people will often come and say the pain is here and doesn't feel like it's in the shoulder, and that can go all the way down the arm. The procedure is done with a telescope about the size of this pin. There are 2 or 3 holes normally, one to look through, one to work through. The shoulder is inflated with fluid so we can see where we're going, and typically the shoulder is swollen because of that, so there is some bleeding and also some fluid around. The tendons can be repaired either arthroscopically, so via the telescope, or through a small, what we call mini open incision, and I would do either of those techniques depending on what's available. In terms of stabilisation procedures, the labrum, which is the lining of the shoulder joint, is typically what we repair arthroscopically. For people who just have a simple labral tear, if there's more pathology, then sometimes we need to open up and repair it open.
Complications?
Yes, as with any surgery, there are complications. Arthroscopic surgery is pretty safe by comparison to other modes of surgery. There is a very small risk of infection, about 1 in 1,000. There is a risk of getting what's called a frozen shoulder or capsulitis, which is reasonably common if you're diabetic. It's about 5 times the number of diabetics have it as non-diabetics, but otherwise about 1 in 100 after surgery. The main risk from my point of view would be the risk of re-tearing the tendons around the shoulder. If you have a large tear, the risk is substantial, so 30 to 40% of people will re-tear to some extent in the first year after surgery. After the surgery, you'll probably be in a sling, especially if you have a rotator cuff repair. We would tend to protect the muscles, the tendons rather, that have been repaired in a sling for between 4 and 6 weeks. In that time, you'll be doing some simple exercises, what we call passive exercises. Again, if you have a shoulder stabilisation procedure, we would rest you reasonably quietly for 6 weeks in a sling, depending on what sort of repair you've had or reconstruction you've had done. If you just have a subacromial decompression, so a clearing out of the space where you're impinging, then we do tend to get you going quickly. And also typically if you have a frozen shoulder which has been operated on, then I will get you moving very quickly afterwards to prevent it recurring. Again, that depends very much on what sort of surgery you've had. If you've had a rotator cuff repair, then typically you would take 6 months to achieve good function afterwards. So it's quite a long time. And especially if people are working, that's quite a significant wad of time off. So it's important to be realistic about what sort of work you're looking at going back to afterwards and the time frames involved in surgery. It's not so much controversies as possibly new techniques. So arthroscopic rotator cuff repair has been around for a few years, but again the techniques and the equipment has improved to the point where now this is being done more and more frequently.